Welcome to today's video on selective digestive tract decontamination, or SDD, in ICU patients. What is SDD? A method used in intensive care units, ICUs, to prevent infections. Involves reducing harmful bacteria in the digestive tract. Aims to prevent hospital-acquired, nosocomial, infections. Benefits of SDD. Proven advantages. Reduces mortality. Lowers death rates among critically ill patients. Decreases infections, fewer hospital-acquired infections. Shortens organ support. Patients need ventilators and other support for less time. Safety. No significant side effects observed. Concerns about antimicrobial resistance. Common worry. Fear that SDD might cause antibiotic resistance. Evidence shows these concerns are largely unfounded. Studies demonstrate minimal impact on resistance. Limited implementation of SDD. Current situation. Despite benefits, SDD is not widely used in Europe's ICUs. Need for practical guidelines. Lack of international guidelines. No comprehensive international recommendations for SDD. Implementing SDD in the ICU. Cultural shift needed. Change perceptions about infection prevention and treatment. Full commitment required. All ICU and non-ICU staff need to support SDD implementation. Importance of adherence. Strictly following the protocol ensures effectiveness. Essential components of the SDD protocol. Target population. All ICU patients expected to stay more than 72 hours. Not limited to intubated patients. Antibiotic use. Use parenteral antibiotics that preserve beneficial gut bacteria. Surveillance cultures. Regular monitoring to guide dosing adjustments. Importance of adhering to the protocol. Negative impact of deviations. Omitting key components reduces effectiveness. Examples of deviations to avoid: not using parenteral cefotaxime. Limiting SDD only to ventilated patients. Skipping surveillance cultures. Evidence from trials. Dutch trials showed success with strict adherence. Our NOSIS trial showed diminished effectiveness when key components were omitted. Safety considerations. General safety. SDD is safe and has been standard in Dutch ICUs since the early 1990s. When to avoid SDD. Patients with severe kidney problems or on dialysis, risk of tobramycin toxicity. Settings with high prevalence of resistant bacteria like CPE. Potential side effects. Rare cases of bezoar formation in the esophagus with long-term use. This diagram illustrates the multidisciplinary approach required for successful implementation of selective digestive tract decontamination, SDD, in ICU patients. It outlines the roles of various healthcare professionals involved in ensuring the effectiveness of the SDD protocol. 1. Microbiologist. Analyzes surveillance cultures to monitor for harmful bacteria. Provides feedback reports to the ICU team based on culture results. 2. Infectious disease physician. Guides hospital antimicrobial therapy in patients receiving SDD. Ensures that empirical treatment aligns with SDD protocols. 3. Pharmacist. Prepares and ensures the availability of ready-to-administer SDD formulations. 4. Antimicrobial stewardship team. Coordinates the overall hospital strategy for antimicrobial use. Ensures compliance with SDD protocols across different departments. 5. ICU physician. Selects appropriate patients for SDD based on criteria. Manages SDD prescriptions and adjusts the protocol as necessary. 6. Infection prevention and control team. Provides hand hygiene guidance. Oversees tools for healthcare-associated infection, surveillance. 7. ICU nurse. Administers the SDD paste and suspension. Collects surveillance cultures. Ensures patient compliance and monitors for potential side effects. The take-home messages are: SDD benefits. Reduces mortality and infections in ICU patients. Collaboration is key. Requires a multidisciplinary team effort. Need for guidelines. Comprehensive protocols integrated into hospital policies. Support services. Pharmacy and microbiology support are essential. Strict adherence. Following the full SDD protocol ensures success. So to conclude, bridging the gap. Implementing evidence-based SDD practices in routine care. Next steps. Develop and adopt comprehensive guidelines. Educate all team members on SDD protocols.